All right, can folks see the slide deck again?
No.
You're not sharing your screen anymore?
Okay. Still not sharing?
Nope.
No.
I don't know what's going on. Let's see. How about now?
Yep.
All right, good. Okay, so we can see the screen now and we're recording now. Welcome to office hours. Sorry about that. I don't know why I was having a hard time getting that up. Welcome to May office hours. And thank you for everybody joining. As always, we're recording our session and it'll be available on the website in the near future. If folks have questions along the way, feel free to chime in or pop in the chat and we'll answer or have discussion as always. And with that, we'll start our monthly office hours. So we'll go through policy and procedure updates as we normally do each month. We got plan of care audit timeline and communication I wanted to walk through since we've had a number of months of discussions around that. Want to touch base on the OMIG audit again and talk a little bit about billing and then children's updates. So policy and procedure updates, we do have a handful this month that we're going to go through, and then just upcoming policies that are coming our way. Jessica, I don't know if you wanted to just jump into what we have for policy updates.
Sure. Can you guys hear me?
I can,
Yes. Okay, perfect. So today we're going to go over some updates to our care transitions policy, the children's core service and billing policy, comprehensive assessment, conflict-free case management, and complaints. And we do have a couple of upcoming policies. Some are going to be updated for changes, and some of them will be due to annual review. You can go to the next slide. So the first policy that we have to review is our care transitions policy. This is an annual review of this policy, so there are no changes to the requirements that are in this. But we just want to make sure that everyone knows that care manager and or supervisor must always follow up on those hallmark events. If you are aware that a care transition has occurred, so ED or inpatient, that a care manager and or supervisor must always follow up on those hallmark events. So if you have a care manager who is out of town, you have to make sure that someone is covering those care transitions for that care manager. They always must be followed up on. The other thing we always want to make sure that is in place is that the consent toggle is on. It has to be utilized. We know that we are having some barriers with our HCSNY right now. It's the HCSNY connection to NetSmart due to some consent changes that are occurring. We are working with NetSmart to get that fixed, but if a member has consented to HCSNY alerts, that consent toggle must be on and utilized. Unless the member explicitly declines consent to allow the information to flow, that is okay. You just want to make sure that it's documented, either write decline on the 5055 or the 5201, or put a note in that they have declined to share their HICS information. You can go to the next slide. So like I said before, a care transition must always be followed up on within 48 hours that you are made aware. You get that notification that the member has had an ED visit. You want to make sure that the care manager and or supervisor is following up with that member. If they've had an inpatient stay within 48 hours of notification, you want to make sure that you're following up with that member and you're attempting to reach somebody at that facility. You want to make sure that you're gathering documentation from the visit and following up with the member. So if that person went to the ED, you're immediately contacting them really within 48 hours. Why were they there? What happened? When is their follow-up visit? What needs to be amended? Is it a care plan? Is there a new medication in place? They've had an inpatient visit, trying to reach them while they're in the inpatient facility, getting hold of a discharge planner. What needs to happen for a safe transition back to the community? When are their follow-up appointments? You always want to make sure that you're gathering documentation, uploading it if possible, documenting in notes. And you want to make sure that the coordination is there for the follow-up appointments. We must maintain that our members have that 7 and 30-day follow-up. It is part of this policy. So you want to make sure that you not only are making sure that those appointments are scheduled, but they're attended. If there are barriers to any of those points, whether it be transportation, there's no appointments available, that you're documenting that, and you can always reach out to the health home. So any barriers with communicating with specific facilities, HICSNY alerts, or anything about MAS or getting your folks appointments, you want to make sure that you're reaching out to let us know. Our managed care organizations are always asking us for feedback when it comes to care transitions and what is going well and what can we report back to them as a barrier. Does anyone have any questions on care transitions? Okay, you can go to the next slide. Next, we have Children's Core Services and Billing. This is an annual review. There are no changes to this policy. The only language we added was an attestation around billing, but that is the attestation that you already select when you're in NetSmart. Just basically attesting that the information that you put and stated in your core service is true and documented in that member's record. So we just reiterated the same language that is in the NetSmart attestation in this policy as well. And I did want to say a reminder to everyone that your interdisciplinary team meetings are a required element of your record. Anyone who is in the low standard, early development, medium acuity range once every year. And then if you're high acuity, complex acuity, you need to have those every 6 months. We are developing a report in DataDen where you can track your IDTs, but I just wanted to remind everybody that these are required and you do need to have these at the frequency that it's set forth by the CANS acuity. You can go to the next slide. So our lower standard billing requirements, again, that's going to be 2 core services a month. One must be a quarterly contact with the member, and at the member's request, the quarterly in-person visit can be waived and you can utilize telehealth. So they can waive this basically all year. You just have to make sure that at least annually you have an in-person visit for assessments and plan of care development and that IDT meeting. You can go to the next slide. For the early development or, one too far. Early development or intensive billing requirements, it's 2 core services. 1 in-person contact with the member a month at the member's request. You can waive that and complete that via telehealth. And telehealth can be used up to 2 times per quarter. And then annually, you're going to have an annual IDT. You can go to complex. Complex billing requirements, 3 core services per month. 2 must be in-person contacts with the member at the member's request. One of those 2 in-person contacts can be waived. And that can be completed via telehealth, and you're going to do IDT every 6 months. We do have a question in the chat that says a desk guide that was previously provided stated low annually and then medium every 6 months. Has this changed? Yes, Michaela, there was a change to policy. I want to say probably about 3 months after this new policy came out. There was a change to policy that they did move the medium rate code to annually with the low and standard group. So low, standard, early development, and intensive, an IDT meeting is required every year. Only complex acuity, it's required every 6 months. And then again, high fidelity wrap would be every single month. But yes, there was a change to policy. I want to say it was like 3 months after this policy came out. Any other questions on the children's billing policy? Melissa is asking if there is a list of approved telehealth platforms. So this is for Children's Health Home only. You can utilize telehealth. The state, so DOH defines telehealth as audio video communication. You do not have to use an approved telehealth platform for Children's Health Home if you are utilizing telehealth in lieu of an in-person visit. The only requirement around that is that the method that you use must be secure and it must have audio and a visual component to be considered telehealth. Any other questions? Okay, we can move to the next slide. Next, we have complaints. This is an annual review. There have been no changes to policy. Just a reminder that every member that we serve must receive rights and responsibilities in a document. This could be your CMA's document. You can use the desk guide that we have in our policy. Everyone must be informed that what they have a right to, and then how to file a complaint if needed. And then just a reminder that if you're serving HCBS youth, they do have a rights and responsibilities HCBS form. That specific form must be issued to those youth enrolled in HCBS, and you must document that you have given the family that rights and responsibilities HCBS fact sheet, then that you reviewed it with them. So you can do that by having them initial a copy and uploading it, or you can do that through a note. But only folks that need a very specific form are going to be youth enrolled in HCBS. Does anyone have any questions about the complaints policy? Okay, go to the next slide. Next, we have comprehensive assessment. The comprehensive assessment was updated early, so this is outside of its annual time frame. We updated this policy because we wanted to make sure that this policy was aligned with what DOH has reported to us and what we have learned through our OMIG audit. So it does outline a very specific billing requirement when it comes to your comprehensive assessment. So adult members must have a comprehensive assessment on file within 56 days of enrollment and annually thereafter, so every 365 days. There is no formal billing block in place to reinforce this requirement, so we encourage everybody to utilize DataDen to make sure that everyone is staying on top of their comprehensive assessments with it not having a billing block in place. DOH is aware that there is no billing block in place. We have had conversations with them. They stand with OMIG's stance that the comprehensive assessment must be up to date, that aligns with your core service that you were given, plus all of the other billing restrictions that we must have in place at that very same time of that core service. So there is no billing block, but you do have to make sure that you maintain an active, up-to-date comprehensive assessment. For anybody enrolled in Children's Health Home, you have a built-in billing block with your CANs. So if your CANs is overdue, you cannot bill for services, and your CANs in the comprehensive assessment have been they have been combined into one assessment. Does anyone have any questions on the update to the billing requirement on the comprehensive assessment?
Jessica, I just wanted to reiterate that the new OMIG protocol reiterates that it's a, an element that they're looking at for the comp assessment as well, that I had sent out to the network last month after office hours. So it is something that OMIG has put into their standards, and they will be looking at on their next round of audits when they do implement that at some point across the state. So just something to be aware of as you're doing your work.
Thank you, Travis. Morgan did add in here. Yeah, so that is, Morgan added it. You guys can go in the chat and read it. It's a very long comment. Basically, that is the definition of telehealth that is used in our policy. It does state that if video isn't available, then you can just use audio. In that instance, it's a phone call. So let's say that you do go to deliver a telehealth service. And again, whenever you document telehealth service, it must be documented in the record that this core service is being delivered via telehealth at the member's request. It's never due to care management convenience. It's always due at the request of the family or caregiver or member. And it does state with the definition in there, we consider telehealth audio visual if there is an issue with your visual aid. So let's say you go to do it via Teams, or you're going to do it whatever platform you have, and for whatever reason the visual aspect is not working, because everyone does have technology issues. You saw it here today in the first 5 minutes. It can be delivered if there is just that audio component. That should not be the standard. So that's why we always say audio video must be a component. But yes, that is in the definition that is right in our policy. Any other questions about the core service billing or comprehensive assessment? You can, Melissa's asking about is Teams a HIPAA compliant video platform. You can pay for a version of Teams that is HIPAA compliant. Yes, thank you, Morgan. Yes, there's always going to be some sort of technology issue that we always have. And in that instance, yes, you can still bill. Okay, you can go to the next slide. Conflict-free case management. This is an annual review. There are no changes to this policy, and this policy is only applicable to our CMAs that also deliver HCBS services. So only applicable to any of our CMAs that are a CMA doing health home care management to HCBS youth, and also deliver direct HCBS services as a provider. You want to make sure that you have conflict-free case management in place. So this means that any of the members that you're assessing for HCBS, you are not directly funneling over to your HCBS provider arm and making sure that they're doing all of your direct service. And anyone who's a direct service provider who's out there delivering services isn't then directly referring everyone back through to your care management department. You must have freedom of choice. Everyone is aware of our freedom of choice form if you serve HCBS youth. When they sign it, when you review that with the family, they have a right to receive their care management from whomever they decide and their services from whoever they decide. There absolutely will be overlap with the two, and they will want to receive it all in-house from one CMA. That's absolutely fine. You just want to make sure that they have an educated, informed decision on that. All of our providers also must have a conflict-free case management policy on file that is available upon request. We used to have you send these to us annually, and we used to have them. No one has ever asked us for a copy of them. So this year moving forward, we just want to make sure that you have it available on request in case any requesting state agency comes to us and says, hey, can I have so-and-so's conflict-free case management policy? I can go to you and say, hey, can you please provide that policy for me? Again, we used to collect them from you every year. To date, no one's ever asked me, so that's why we're moving towards just making sure that you have it available upon request. And again, this is only applicable to our children's health home who serve HCBS youth as a care management agency and then also as a provider. Any questions on this policy? All right, back to you, Travis.
All right, thank you, Jessica. A lot of policies this month. There's gonna be a bunch more coming up. Springtime always has a big influx, so bear with us as we go through these. Thank you, Jessica, for going through all those. Wanted to take some time to go through plan of care, audit, communication, and timeline. We had a meeting last Wednesday, the 20th, with the supervisors around the plan of care audit update. It was a session that we talked about it on office hours, that we were going to hold a special office hours, if you will, around the plan of care audit and where we were to date as a health home on communication and timeline and basically just kind of the status of the plan of care audit in general. So that's what that meeting was about. And one of the slides was this particular slide here, just walking through the various points throughout the last 7 months of different things we've done as a lead in communication and not only along the lines to the network, but with the state and checkpoints along the way. So I just wanted to share that slide with this group. This whole thing started back in October of last year when we were approached by the Department of Health about a compliance concern potential, and it all stemmed from their doing a redesignation review with another lead, where they identified a concern around plan of care signatures and dates not aligning. And as a result, they reached out to all lead health homes that were utilizing NetSmart. And we were one of 7 leads that were impacted by their compliance concern. And then that resulted in, and I'm not going to go through all these points here, but that resulted in on 11/13 of 25, us receiving a written notification of a compliance concern requiring corrective action, which ultimately kicked off the formal audit process, where we had to conduct an audit with the network. That put forward us having to submit an action plan, which we did do so. We had to do that within a very short time frame to the Department of Health. They didn't actually approve that action plan until March of this year, which you'll see further down in this timeline. But that didn't preclude us having to take action and have to move forward on our action plan because during that time frame from November through March, we had to have, and we still have, we actually have it this next Friday, our next TA call with the Department of Health, technical assistance call. We've had monthly technical assistance calls each month with the Department of Health on the progress of our audit and our actions with this audit. And we have to show our action and how we're doing and moving forward to complete the audit. So with this, I just wanted to show the network in general, just the things that we've done throughout. The slide deck from last week's meeting, I'm going to send out to the network after today's meeting as well, along with today's slide deck from office hours, just so you have that, along with the frequently asked questions that were given to the supervisory group as well, because there was a bunch of questions that group had submitted to the lead team around the plan of care and the audit process. So I wanted to share that with this larger group as well, just so that folks would have that for transparency. And You'll find in the slide deck and the FAQ document, a lot of the questions that have come up through this venue as well when we've met over the last handful of months, should be answered or should be, at least, identified through this slide deck and FAQ document. We're hoping to continue to improve on our communications. I know there's been some concern at certain points about effectiveness of communication, and I want to extend our sincere condolences that we haven't been as effective as we could have been in certain points, and we'll continue to strive to be better. We want to continue to partner on and being as efficient as we can in our communications and be the best partner that we can with the network. We have our new quality manager starting up this Thursday. We're really excited about that. Megan DeMail will be joining us. So we look forward to working with her and her getting to know all of you as we move forward. And we look forward to her ideas that she brings as she comes along and developing those partnerships with each of you as well. I didn't know if anybody had any questions at the moment, but I wanted to pause before we move forward specific to this particular slide. Okay. We did get some news Friday afternoon from the Department of Health that came through around contemporaneous documentation is one of the questions not only our health home, but some other health homes had going through this process brought forward. I know the network, we had some care management agencies that asked this question to us as well, whether contemporaneous documentation could be allowable in the absence of plan of care signatures and dates. And the department responded back to us. I did send this out to the supervisor group earlier this afternoon, just prior to our meeting today for office hours, with a screenshot of the actual DOH response to myself last Friday afternoon, or late morning, I should say. Ultimately, they did say that they would allow contemporaneous documentation. It's got to be within the timelines of the actual requirement for timeliness for initial or annual plan of care development. And it has to really indicate and show that the member was involved in the process and that they were in agreement with the process as well. One of the things that DOH also responded back at attestations or verifications that are not contemporaneous with the completion of the plan of care are not acceptable. So it has to fall within that time frame, and it's got to be timely in the time frame of those documentation for the plan of care when it was to be due. So with that, we wanted to get that information out to everyone. We can go back and look with you and partner with you to look at your audits. And if you have documentation that is contemporaneous for those organizations that have completed your audits, we can look back with you. You can take a look at your audit tools. If you find information in your charts and you want to present that to us, we can absolutely look at that as well. And we can take another look at the results for those organizations that are pending still. You can absolutely look at those audit tools and take a look at that. And if you find information that you feel would be supportive, please make us aware. We will absolutely look at that as well. And we want to, take a look at that and see if there's information that would help support bringing down those potential takebacks that have been identified. So I wanted to stop there and see if there was any thoughts or comments around or questions. We will be updating the FAQ and frequently asked question document that'll be sent out and have this information included in that as well. Okay. OMIG audit. We are getting really close to submitting the response to the draft audit response. Our attorney is finalizing the report from everything that we've collected. We're doing one last final review of things. I appreciate all the supervisors that responded back to our outreach. We're trying to pull everything that had alignment with the data service that was identified for those individuals that were part of the sample, because that's what OMIG is looking for. Anything that was not tied to data service, unfortunately, is not going to be identified for OMIG to be acceptable. But anything that was tied to the data service, we're trying to see if it's going to be applicable. As far as supportive documentation and what we believe will be, we're going to submit, see if it'll stick and be accepted. June 1st is the deadline for submission, and that's our intention to get everything in. And once we get the final determination back from OMIG after that submission, which we don't know how long that's going to take, given the timeline they've been working with, it's been very open-ended. Once we've submitted, they're a week, a month, 2 months, 3 months. It's hard to determine when they'll be responding after we submit. But once we do get a response back, we will be in touch with those providers that will be impacted once we have an understanding what that is, and we'll be in discussion with next steps. But that submission is going to be happening within the next week. Any questions around this particular topic for OMIG? Well, please reach out if you have anything you want to reach out separately on. Next thing is around billing. So we've had a lot of people reach out around billing over the last, several months, and we've been doing a lot of work on the lead side and with our administrative team at AHI to try and look at how we can create more efficiencies around billing. As a lot of you know, we had a long-term staff leave last year, which took a lot of knowledge with them, and we've been trying to stop the gap and fill the gap around billing. And we really are coming up with some new processes around that, which we're going to be announcing pretty soon here. And it's going to, we believe, include improved access to information for folks around billing for you, more timely resolution. And it's going to include tracking, consent, and plan of care and assess access for you all as well. And we're excited about it as a lead, as an organization, and we're hopeful that you're going to be as well. And we're looking forward to these changes. Not quite able to announce it fully yet, but I just wanted to give everybody a heads up that there are going to be changes with the billing that are going to be coming very shortly to be announced. And it should be a positive thing for the network. And it's going to answer a lot of questions that people have been bringing up and accessibility, et cetera, for folks. So stay tuned. It's going to be happening soon. All right, Jess, I'm going to turn it back to you.
Alrighty, so the rest of the slides that we have for today are exclusive to children. So if you only serve adults, feel free to hop off if you would like. So the first thing I have is a high fidelity wrap update. My update is there is no update. We just had a meeting this past week. The holdup with the expansion is we do not have enough OMH trainers to expand high fidelity wrap. So it is business as usual, except for Clinton and Essex County. If you are in Clinton and Essex County, you are our only covered counties for high fidelity wrap. So any youth that resides in those two counties, you're going to continue to screen. Well, everyone's going to screen in the UAS. But once that screening has happened and they may be eligible, that's when you need to have the discussion, offer the service, and then complete a transfer if the family decides to move over to high fidelity wrap. So the update is that there is no update, and it does sound like it's going to be quite a bit of time before there's another announcement. But I just wanted to do a pulse check on high fidelity wrap. It is not forgotten. We just had a meeting, and unfortunately the expansion is delayed. Anyone have any questions on high fidelity wrap or anything you want to bring forth? Okay, you can go to the next slide. There was a recent webinar that was sent out, and it's for a new service, transitional care coordination. This is an HCBS service. So this is going to be specific for youth who are transitioning out of an excluded setting, and they're coming out of that excluded setting and they need support transitioning into the community. So they will be assigned a transitional care coordinator prior to them being assigned to a health home care manager. So within our network, this is going to be a new pathway for referrals for our downstream providers. What it will look like is the transitional care coordinator will start working with the family, see what they need to make sure that there's a safe transition home. While they're working with them, they're going to identify a health home and a care management agency to transfer that member to. This is extremely short term. We're looking at 60 days. That they're going to be working with that member. And then that last 30 days, they're going to be looking for that warm handoff and transition to a care management agency. There are only going to be seven agencies initially designated as a transitional care coordination agency. We do not know who those are yet. They have not finalized their designation, so I cannot tell you who they are. What I can tell you is that this is going to be extremely limited. They believe in the first year that there will only be about 50 referrals. So it is likely that the North Country won't see any of these referrals. But there was a webinar. I pulled these slides directly from that webinar that was shared. And I did want to let you know that this would be a new pathway. And then some of the providers that you collaborate with, you may see one or two of them be a transitional care coordination agency at this time. I do not have a list of who those providers are. We will not know until they have been designated. And again, they're only looking about a 50 referrals statewide for the first 12 months of this implementation. You can go to the next slide. This next slide will just go over who would be eligible for this transitional care coordination. So this is going to be the youth that the TCC is identifying. And then all of these folks will have HCBS. They will have HCBS in place, and they will come over and be warm handoffed to the health home care manager to take it from there. And then the health home care manager will maintain their HCBS eligibility. So it's going to be similar to those CS transfers. We do see those CS transfers rolling in under the new process. And now that DOH is doing those transfers, it is seamless and it is going much, much better than it was before. So I anticipate that this transitional care coordination will be as smooth as the new CS process. But again, very low enrollment for that first year, very low census, but it is something that is coming down. You can go to the next slide. And this was effective, I'm sorry, 4/1. So technically it's started with the new waiver that's in place, but there has not been a list of designated providers issued. Something that goes hand in hand with transitional care coordination is transitional service. This is a bucket of funds. This is another HCBS service. It is a bucket of funds that can be used by the transitional the transitional care coordinator to get that youth home safely from their excluded setting. So it can be used to cover all sorts of things: moving costs, furniture, security deposits, home furnishings, utility setup, making sure that that house is safe, that they can transition home to. And one of the other things that is in this waiver that I did not put on the slide is it will allow the transitional care coordinator to start any modifications that need to be done to the home or vehicle in advance of that youth actually leaving the facility. And then the health home care manager would pick that up and see that through. So this is all around making sure our youth can transition safely out of those excluded settings and back into the community. Again, not all children who are in excluded settings will be eligible for this. And they're anticipating very low enrollment, but hopefully with the transitional services and transitional care coordination, we can transition some kiddos out of facilities that have kind of been there long term. Does anyone have any questions on this? Again, there was a full 1 hour webinar. Slide deck was sent out after that, but I did want to touch base on today's meeting in case you couldn't make it. Any questions? All right. If you do have any questions or anything comes up, please feel free to reach out to me. That was the last slide, but I also just wanted to let everybody know that it's Travis's birthday. If you want to give him a birthday shout out, I'm sure he would absolutely not love that, but I just wanted to let the group know it is his birthday.
That's awful kind of you, Jessica. Thank you.
Oh, you're welcome. I would absolutely hate it, so I had to do it to you.
Is there anything anybody else wanted to talk about or bring up for discussion today? All right. Well, as always, thank you for everything you all do each and every day, and I hope you have a good rest of your day. And thanks for joining.